promise. So we heard a lot about the axilla. Thank you for the invitation. Thank you for being here. It's always a pleasure. This year without the masks is better. Okay, so um, I was talking with Omar about some of the things that happen here in Egypt, because I think the talks are more interesting when they are directed to what we do. So I have no conflicts, and we know all of this. So we know that we came from a long pathway and we improved a lot, and we still remember and we still see patients with very, very large lymphedemas, and this is starting to change, and this is very important. The problem now is where we stand and what is going to happen in the future. So are we going to simply dismiss axillary dissections? We are now in trouble to teach axillary dissections to our students. Is this going to happen in some forms of tumors? Are we going to omit also sentinel nodes? So this is something that is complicated. So this is what we know. And what we know is CN0, we are going to do sentinel node in upfront surgery. So we know that Z11 and Amaros showed us that 1 to 2 positive nodes is good if we go into upfront surgery, and then we can have radiotherapy in case of the Amaros, or radiotherapy to the lower axilla. Sentinel node biopsy after neoadjuvant chemotherapy in ultrasound negative axilla before chemotherapy. In N plus 1 to 3 positive nodes, they are converted to negative nodes. We can still go on sentinel node or tagged axillary dissection. Axillary lymph node dissection is still recommended for any residual nodal disease after neoadjuvant chemotherapy. And in case, and I remember that was a question about neoadjuvant endocrine therapy, about what to do, and what we know now is neoadjuvant endocrine therapy behaves much more to the setting of patients with luminal cancers submitted to upfront surgery than in patients after neoadjuvant chemotherapy. So going very fast, so this is the trials everyone knows, and we have all the settings that prove before that we can do sentinel node, then that we can do sentinel node with 1 to positive nodes, and much more than the trials that we are based on to do our attitudes now, we have several ongoing trials still confirming the endpoints of these previous trials. So now I think is the most important things. So we have always doubts, even with the trials. So if we have early breast cancer in a patient that is luminal A-like, and it's not 19 years old, has not lots of comorbidities, are we going to spare the sentinel node? This is the question that was already approached by Terry Mamounas, and I'm just going to show you the trials, not going further on that. Then if we have a patient, and I know because Omar told me you all do ultrasound to your patients, so almost all do ultrasound, even in patients that go for upfront surgery. So you are bound to have these cases on when your imaging says that you have only 1 positive node. Is a postmenopausal young patient, postmenopausal fit patient with a small tumor that has one positive node and has a Ki-67 or 5%. These patients should go onto axillary lymph node dissection, as we know from the trials. But this is not fair, because these patients will have, in at least 40% of cases, only that node that is positive. So why can we not treat these patients according to the Z11 or the Amaros? The other question is, when you go for a sentinel node, and you have only 1 retrieved node, and only this node is positive. You don't have any node negative. So what usually our medical oncologists ask is, I don't know the exact burden of the axilla because I have only one or two positive. So I need to have the ratio between the negative and positive, and this can make a difference. So I'm going to show you, this is just the omission of the sentinel node, all the trials that are ongoing. So regarding this problem of the patient that has imaging in ultrasound positive axilla of less than 3 positive nodes, so the criteria of the Z11 and the Amaros, but you detected this before surgery, and this patient is not going for neoadjuvant chemotherapy. What we know? What we know is these patients usually have more positive nodes than the ones that have a clinically negative axilla. This is for sure. But what we know is we have at least 40% of these patients that don't have any additional nodes and could be treated according to the Z11 and Amaros trial. So what we do in our guidelines is this. If the patient is postmenopausal, luminal A, as clearly a cancer that is for breast conservation, and if the sentinel node was negative or positive 1 to 2 will be proposed for the Z11 or Amaros, what we do in these cases is we do sentinel node, okay? So we go for surgery, we do sentinel node, we can clip the node or not. I know that also Omar told me that you use blue dye, and with blue dye, you usually have more retrieved nodes than when you use the radioisotope, because radioisotope is more focalized than blue dye. So you have a larger sample, and this allows you to conserve the axilla more. And we have this in several other retrospective analyses, and we need to understand this is a meta-analysis by Dweck, and we have several retrospective analyses. You have this recent analysis that shows you what all the others show, that you need to be aware of something that we all are aware, that is lobular histology. Usually you have many more nodes than the ones you expect. You need, of course, to be aware about tumor size, nodal metastasis size. This is important. If you have a large metastasis size, usually you have a higher nodal burden. So it's important to understand this is a cluster of patients that at this moment we are treating badly. What about only retrieving one node out of one positive or 2 out of 2 positive? Of course, this is only important in the setting of luminal cancers, because the rest that is triple negative or 2 positive, we know what to do. So this is something that has been progressing according to one trial using Oncotype DX that I know that you don't use because it's not paid for. Don't be sad, in my country it's not paid for also. So what we do is, in private setting, we ask the patients to pay for it, and they pay. If not, we need to decide without the Oncotype. So imagine that you have a luminal patient that either she is axilla negative or axilla that was ultrasound positive 1 to 2 nodes. You propose for sentinel node, and you don't have access to the Oncotype DX. So in fact, the responder trial results that are on top of the table saying that in postmenopausal women that have less until 3 nodes positive, you don't benefit from adjuvant chemotherapy. But if you don't have the Oncotype and you have only 1 positive or 2 positive nodes, your medical oncologist is going to ask you, how do I know if I don't have 4 positive nodes and this patient needs to go for chemotherapy? So in these cases, when you don't have access to the genomic tests, either Oncotype or Predict or MammaPrint, whatever, they are all the same, you can go for an axillary dissection to understand the real burden of axilla. So this is something that we know will help us to understand what to do. And what you see here is exactly a summary of a retrospective analysis comparing the Dana-Farber's cohort of patients with the National Cancer Database. And what you see is usually when you have more positive nodes, you usually tend to propose those patients to chemotherapy, because in doubt you propose. What happens in the Dana-Farber, because it's a limited environment, people are more conservative. In the National Cancer Database, they are more broad and more chemotherapy is done. But this is what we have. We don't have any evidence that we can spare our patients the idea of having an axillary dissection to understand the burden of disease if they can profit for chemotherapy, although in the longer outcomes of these trials, the overall survival was exactly the same if these patients had endocrine treatment or if these patients had chemotherapy and then endocrine treatment. So it's something that is not clear, but I can tell you that in my institution, when we have doubts and when we need to know the burden of disease to decide, we go for axillary lymph node dissection. This is a minor proportion of patients, but it still exists. So we talked about post-neoadjuvant, so the questions here are omitting sentinel node in exceptional responders, and Terry talked about that. In N+, returning to N0, the question is always the same: which node to mark? Mark only one if you have 3 or more. And then what technique are you going to use to identify the node? We have also his opinion about that and the results of all the trials. And what about a positive node after chemotherapy? If it is isolated tumor cells, micromets or macromets, at this moment, we should undergo axillary lymph node dissection. Can radiotherapy replace this? What about locally advanced breast cancer? This I'm going to leave because at this moment we don't have data to go on that. Oh, sorry. So this is the exceptional responders. What you know is in luminal, it doesn't work. In triple negative and HER2 positive, when you have a negative axilla before starting neoadjuvant and you have a complete response, the rate of having positive nodes in the axilla is really very low. If it goes to T2, and some of the trials already include T2 or a positive axilla presentation, this changes and the rate of positive nodes after is higher. Don't forget that having positive nodes or not, at this moment, is not only a problem for radiotherapy, but also for deciding adjuvant treatments, mainly the new cyclin inhibitors. If we have more than 3 nodes in my country, we can propose the patient for cyclin inhibitors in adjuvant trial. So it's important to understand what's the number of nodes. Of course, in luminal, we don't have these exceptional responders. So trials on omission of axillary surgery, we talked about, so omitting sentinel lymph node biopsy in these exceptional responders is going to be studied in these trials, and this is only considering tumors triple negative or HER2 positive. This you know. And what about the type of marking that you are going to use? This is something that I think is very important, because if you don't use dual tracer, if you use sentinel lymph node biopsy, you can think that you are sort of prohibited to have this observation after neoadjuvant treatment. I don't think it's like that, because I know that you have ultrasound and you clip the node when it's positive, if it is possible to do it, or at least put a carbon marking. In many of the trials, so these are the Dutch trial where they use the radioactive seeds, in many of the trials, you don't have a tagged axillary dissection. So In the memorial cohort, you only go for sentinel node, and they don't even mark the node that is positive. And you don't forget that you have used sentinel lymph node. So I know that the false negative rate with sentinel node marking with one marking is higher, but you can still study your patients and see what's happening, because it's not impossible to do it. To compare these two things, this also was in San Antonio, is the results of the prospective cohorts analyzing retrospectively by comparing the sentinel node alone with the TAF in two groups of patients and showing that there was no difference whatsoever in local regional recurrence rates at 3 years. Of course, overall survival is not coming from the 3 years, so we don't know. But this is something that we know now. Another thing that we know is when you use dual tracing, so blue dye and radioisotope, you take out more nodes than when you use only the TAT approach, because it's more directed. So, and this is something that you all can participate, because this is going more and more. So using large population prospective cohorts from the real world population to investigate how different forms of marking the nodes will end up in the follow-up. So the Axana study accepts every type of marking and is for patients that were CN plus and are C and 0 after chemotherapy and before surgery. And they accept every type of marker, and this trial is accruing highly in a very fast way, and I think we'll have very interesting results soon. Now, the last thing before I put you a challenge is, what about the axilla that still is positive after chemotherapy? This is happening mainly, and we're talking about low burden disease, nor locally advanced, very advanced disease in the axilla, and we are starting to replace these isolated tumor cells, micromets, and even macromets for radiotherapy instead of anything else. And this is something that we recommended in a last paper that we published in 2021, is if you have an axilla that is supposed to be negative, you're going to surgery, your perioperative exam, yes or no, is negative, and then you have a positive result, do you need to go there again? And we stratify the patients in low and high risk and decide that in some situations you can replace axillary lymph node dissection by radiotherapy. Again, if you need to have the information to go on special adjuvant treatments, you maybe need to go on axillary lymph node dissection. So, my challenge, 27 years old, T2, multifocal, so not conservative Ahadi, okay? She was on neoadjuvant treatment, mother and maternal aunt, both BRCA2, pathogenic variant, and breast cancer both. And this girl did a genetic test. No, she did several genetic tests because nobody believes that she's negative, but she is. And she had a multicentric tumor that was luminal, high risk, and one positive node on the axillary ultrasound confirmed with core biopsy. And the node was clipped, and the lesions of the breast was clipped. She had neoadjuvant dose-dense chemotherapy in Brussels because she was working in Brussels. The genetic test, as I said, was negative. The final imaging pre-surgery, she has a response that was not magnificent, that is usually the case, and the positive lymph node was normal on ultrasound. So the thickness resolved and it was normal. So we discussed a lot with her, but she didn't accept anything besides bilateral mastectomy. She could not live with that, and we understand that because in this case it's very complicated to be able to live with a situation like this. So we did a mastectomy and a prophylactic mastectomy, and We did an Axana, so a sentinel lymph node attacked, removed the clip and the sentinel node, and the result is there. So she had 3 lymph nodes. The clip node had a macromet that was negative in the perioperative exam with 6 millimeters and fibrosis, so it seems to have some response but not complete response. The 2 other nodes were negative. Tumoral bed had several foci. The 2 were the major ones, 15 millimeters and 40 millimeters, and multiple infracentimetric foci, and with the cellularity between 70% in the foci of 15 millimeters and 15% in the largest one. So this patient has a residual cancer burden of 3.4, so a class of 3. So in this setting, what you recommend for this patient regarding surgery before she undergoes, because she knows she will need radiotherapy, what you recommend? Axillary dissection. Will recommend. Don't be shy. Okay, so we didn't recommend, but Brussels did recommend us. So talking about Jules Bordet, so we didn't, and they did. Because why? Because this girl is the candidate to have the compassive use of cyclin inhibitors if she has more than 3 positive nodes. In this case, she needs to have this confirmation. I don't think she's going to have more positive nodes, to be honest, but she will be treated in Brussels, and she decided to go on that. And this adjuvant information will change the treatment for this girl, because if she doesn't have these 3 positive nodes, she will not go on the compassionate use of cyclin inhibitors. And this is the case. Just before finalizing, because this is not the last, but before the last slide, this morning, this girl had a HER2 1+ in one of the biopsies, and the other one from Brussels was HER2 2+. They sent to SISH, and it was negative. And we repeated not the SISH, but the FISH on the larger KI sample, because she was again 2+ on our post-op exam. And when we have this in a different institution, we repeat the FISH, and it is positive. Okay? So every rational, so the girl is completely messed up, because you don't even imagine how many times she was going to this and that and to this and that. So this, and I usually give my slides to Omar, and he can distribute. This is a workflow of what we do in axillary approach. And to conclude, axillary approach is still evolving. Trials ongoing will give us more answers. So we need, of course, randomized trials, but large population cohorts are very important. Avoid over and under treatment requires knowledge and common sense in daily practice. It's not knowing only about surgery, it's knowing about everything. Breast cancer treatment is really multidisciplinary. Escalation and de-escalation are dependent on everyone, and several factors should be taken into account at the moment a trial is designed. Thank you. I think everybody is tired, and I completely understand.
No, but let's open the floor for any questions. Yes, please.
Thank you very much, Ms. Cardoza. If I get this correctly, this young lady is BRCA negative.
Yeah.
Yet, like, there's a couple of people in her family. Yet, why will she eligible for CD4? You said something about 3 nodes in order to be eligible for CD4/6 inhibitors?
Yes, the compassionate use of CD4/6 in adjuvant in many of the countries in Europe demands either a grade 3, okay, or having a grade 3 that she didn't have, or having at least 3 positive nodes.
Okay. let's say that she get the dissection done, and yet out of 20 lymph nodes, you still have the one single macrometastasis, 6 mm one. What will be the next?
It will be ovarian. So if she doesn't have more nodes and she was still a luminal, because now we have the HER2 positive, so she's going to change everything, she will be candidate for ovarian function suppression and aromatase inhibitor.
Despite the fact that she's BRCA negative.
Yeah.
Okay, the last thing, you talked about the HER2 negative, and down the line turns out we tend to have the heterogeneity of the tumor, and it depends on the biopsy which edge of the tumor has been taken out. Could it be the case, like she's HER2 positive from the get-go?
Yeah, you can never know. So when we translate from one place to the other, we always revise the blocks of the pathology, always. And she had 2 core biopsies of the larger, because in the imaging and the MRI, it seemed like a larger node on one of the locations and a smaller one. She had 2 representative biopsies of 6 cores in each of the samples. Okay, and she had 1+ and 2+, and the 2+ were confirmed by CISH, okay, and it was negative. So when she came, we did everything except the repetition of this, because she will have surgery. We knew that she didn't have a complete response, and usually we repeat that on the specimen of surgery, because otherwise she needs to pay for everything again. This was a private patient in our setting. She only has insurance in Brussels. So the tumor that had still 70% of cellularity was HER2 positive, 2+. So we asked for a FISH, and she's really amplified. It's not a borderline, she's really amplified. What I asked, so I talked, she's been treated in Brussels by Evandro de Zambuja. I don't know if you know Evandro. And what we decided was he will talk with her, propose her for the PER2 and trastuzumab and hormonal treatment more soft, because now she's a HER2. And I asked my pathologist, although this is not going to change, to see what was the biology of the metastasis, just to be, because, you know, these heterogeneous tumors, this lymph node didn't respond. The metastasis is still 6 mm, okay? So she has a very small thin fibrosis on the node. The node was big, that's why it was negative on perioperative exam. So I'm curious to know what type of tumor metastasized to the lymph nodes. For me, it's interesting to know. But this is a very difficult case, but we have difficult cases that challenge us every day. And these difficult cases are only dealt with a proper manner if we know more than just surgery.
Any more questions?
Thank you. Move to the
Thank you very much, Professor
Thank you.
Cardoza. And now we're going to move to